Welcome to Raising the Bar, the podcast that pulls back the curtain on the country's most successful leaders and how they elevate their business and their teams. Please welcome our host, Alison DePauli.
Today, we are going to talk about direct primary care with my friends, Dr. Wes Clements and Jen Clements, who own SADPC and an individual practice under that called Tailored MD. So you're going to hear both today. And I think many of you know that I am a huge fan of direct primary care as a patient myself, and I can see what it does for both employers and employees and how it can benefit each party. So I thought it was be really important for us to talk about that. One of the things that I hear quite a lot is that, well, why would a doctor want to do that? Well, today you're going to hear why. And I think you'll get a better sense of how much of medicine is the business of medicine and how there is a large and very rapidly growing number of physicians that really just want to be doctors, and how DPC is a way that they can practice in their own ways, because not all DPC practices are the same. So how are you this morning?
Good.
Doing well.
How are you?
I am all right. Some days it's good to be blonde. Tell me, I want to go back to why you started DPC. You are one of the few physicians, Wes, who I don't believe you've ever practiced in a system. You have always been out on your own. Is that right?
Actually, there was a short stint of doing traditional primary care, working for the man for insurance. And I did that for 2 years before I opened my practice 3 years ago. So I've been out of residency for 5 years, 2 of which were an insurance-based practice.
And you came here and you started a practice that is growing like wildfire. And now you have moved from Tailored MD into SADPC. So this is a business model and a viable business model for you.
Correct. It's more than viable. It's been fantastic, actually. A lot of career satisfaction in practicing medicine the way I love again. And yeah, you're right. So it started as a small practice, and we're growing a network in San Antonio called SADPC, a group of different direct primary care practices. So we can work with employers and cover a larger area for individuals as well. But absolutely, definitely satisfaction is much higher, which, I mean, you could say maybe isn't saying much compared to the doctor satisfaction in the traditional model. I'd say that's not too high, but it's in a different world of career satisfaction for sure.
So I know several DPC doctors, but your office has to be the most interesting one I have ever been in. It does not look like a medical practice at all. And you typically, you're sitting in your office right now, actually, with those beautiful bookcases behind you. And you typically, and your beautiful wife, and you typically sit across, you typically sit on the other side of the desk and talk with your patients. And then you have an exam table. And I believe you told me that gets used not very much.
Right. Yeah. It's a very casual environment. When you walk in, you're right. This is my office. I'm sitting at my desk, and actually you're virtually sitting right where my patient would be sitting, across from the desk, and we chat. We come in, they don't go straight to the exam table and sit there like some specimen to be examined later on. They come in, we chat, it's very relaxed. We have an hour to an hour and a half to visit with the patient in person. And then, yeah, if an exam is needed, we sometimes go to the table. You can listen to heart and lungs in a chair, though. You don't have to put them up on an uncomfortable table. And it's got, the rug. It feels kind of like a living room almost.
It does. And I would imagine it puts people at ease. Sorry, Jen.
When you walk into the office, the first room you see really does look like a living room. We've got a couch, 2 chairs. We have one desk set up where MA sits, and we like to call it lovingly the no waiting room, because our patients don't have to wait when they come in for their appointment. We're ready to see them. So really, it's there just for looks. Sometimes it gets used, but we like to make it a homey, welcoming environment where people can bring their whole family. Their kids are welcome here. Their spouses are welcome here to wait while they're seen. That's what we were going for.
Let's talk about that, spouses and children, for a minute. You treat employees, you treat regular patients, individual people that find you, and you get a good flow of those people who find you and are looking for individual medical care, because that's what you deliver. You don't deliver insurance. Mm-hmm. And if somebody is having a heart attack, they're not coming to you, they're going to the emergency room. And if they're receiving chemotherapy, you might be supervising that, but you're not delivering that.
Correct.
So you can take care of a lot of somebody's day-to-day medical need. And I would imagine you can also help cut down on some of the extraneous things or the more expensive things that happen that may not be necessary.
Yes, I'd like to tie that into the satisfaction too, the doctor satisfaction of practicing, because I think what increases doctor satisfaction in this model is we get to practice medicine the way we learned and the way we imagined, which is to the fullest extent, really utilizing our knowledge instead of being just a cog in the wheel of the machine. In primary care, that cog is basically just a referral coordinator, it feels like at times. So when we can practice medicine to our fullest extent, yes, we're way more satisfied because we're using our skills. But what you're referring to is we get to actually do a lot in primary care, which is underutilized in the traditional insurance model. A lot of clinics don't do this anymore, but I can do in-office procedures a lot, stitches and toenail. Well, I don't do the toenail. Our other clinician, Nicole, she will do toenails, but we do those kinds of services, toenail removal. Dermatology stuff, mole removal, biopsies, a lot of women's health stuff, pap smears, coordinate mammogram studies, things like that. Weight loss. Everything really. And then, of course, your bread and butter stuff that we see all the time in any primary care clinic, cholesterol, hypertension, things like that.
So I want to give you an example of something that happened to one of my clients and sort of compare that to what would have happened to that person had they been in your office.
Okay.
So I have a client that they do not have a direct primary care relationship, and they have a spouse. The spouse is a husband, which is typically not typical, but the spouse is a husband, and he is diabetic, overweight, not really getting a lot of care. And he went to a primary care physician who threw about 5 medicines at him, including some very expensive medicines that you have heard me go off on a tangent about. The wife came into HR and they got me on the phone. We got him to an endocrinologist, and the endocrinologist was like, no, we're going to take you off every single one of these. And so many of his problems have stopped, right? And I think one of the things that happens in primary care when you have 7 to 16 minutes is you may get to the first issue, you may write a script for something, and then you're referring out because you don't have time. Is that an accurate assessment?
That is accurate. And that's what I mean by you can't practice to the full extent of your license and really take care of an issue when you only have 7 to 16 minutes. So you end up having to over refer. And so people have 5 or 6 different clinicians who are all different specialists, sometimes with contradicting recommendations. When really probably, maybe they needed one of those, but primary care can treat most diseases up until the end stage. So we can treat fatty liver disease until end stage. We can treat heart disease until somebody needs a procedure, a stent or whatever. Diabetes, you don't need an endocrinologist for type 2 diabetes in all cases. You really don't. Sorry, endo. We need you for insulin pump management and sometimes tough to control diabetes, but a primary care physician's perfectly capable. So in your case that you mentioned, primary care should be able to manage type 2 diabetes and not have to refer to endocrine, especially at the beginning when the first steps are obvious. But I don't want to say it like it's just a beginning thing. You can manage, a primary care clinician can manage diabetes through their life. And that would save a lot of money. Diabetes, I don't know the numbers, you probably know them better than me, but it's one of the highest revenue producing diseases in the American health system.
Yes, it is.
Probably just after heart disease and cancer, I imagine. So the health system, I don't want to sound like a conspiracy theorist or anything, but let's just say the health system isn't really incentivized as a whole to really be cost effective. We know that. So that's not conspiracy theory. So we kind of approach diabetes, I think, systematically as kind of a management thing. So we treat people long term. That's great. We manage it. We get their A1C down. That's the goal. Get your A1C down below 7 or 6.5 if you're not on insulin or something like that. And that's a great revenue producer. Somebody's got diabetes now for their whole life. You're managing it. They're seeing a primary endocrine. They're seeing ophthalmology to get their annual eye checks.
Nephrology.
Yep. Nephrology for kidney management. When in reality, now we have tools that can reverse people's diabetes. It's just such an exciting time. And especially if you have the tool as a primary care of time to talk about diet and exercise, more than just saying do diet and do exercise. We have time to break it apart in their daily habits and create a good intervention that's effective. I've seen it many times. And now some great medicines in the last year or two that can be used temporarily to reverse diabetes. I think we're going to see the recommendations change on standard diabetes management. And the nice thing is we as primary care doctors have time to really take advantage of those novel therapies and create the best outcomes.
One of the things that is very underestimated in the metabolic syndromes, let's call it that, because there are so many people that are kind of in that metabolic syndrome, pre-diabetic, diabetic kind of journey where we are in South Texas, is who is cooking and what are they cooking? And I don't think if you have 10 minutes to spend with somebody, you're getting to cooking, right? And that is, I think, one of the most challenging things. And I know that's not necessarily a high use of your skill set, but it's a very important use of your skill set.
Mm-hmm. People want that information. That's why they don't. I think trust in the medical system with doctors are at all-time low because we're not taking the time to offer those, and other people are who aren't in the medical system. And we need to really take that control back in primary care to offer that kind of advice. Exactly. And time is what's needed for that.
So what is the business case for an employer to offer direct primary care? Besides this is good for the humans. And I'm a very big fan of this is good for the humans. And, sometimes we just have to do something good for the humans. But
it definitely is getting their employees access to care.
Yep.
It's the main selling point for employers. This reduces absenteeism. This reduces when patients have a direct primary care, they're taking care of their preventative health. They have access to a doctor that will overall make them healthier. Along with those things, it's just doing good things for good humans, like you mentioned, is the cost savings. So I just last week signed on a hospice company, 9 employees. We are saving them $1,400 a month and saving them about $16,000 a year, replacing their traditional insurance with direct primary care and an insurance alternative. That is a comprehensive plan for them, getting them more care than they were getting before, better access, and saving them $16,000 a year.
And for an employer with 9 lives, $16,000 is a meaningful amount of money.
It's a lot of money. It's a lot of money.
And the keys are not sacrificing quality or level of service. As a matter of fact, they're improving it. So it truly is the best of both worlds. I think a lot of employers, the biggest barrier we see to explaining the model is it just sounds like we've all said it's too good to be true. Like you can't have better care for a lower price. That just doesn't make any economic sense. But when you kind of deconstruct the whole system and build it up to only service the provider and the patient, and get rid of all the extra crap, then now you have an efficient model that means that very thing.
So there are 3, depending on your health insurance arrangement, if you have a health insurance arrangement, 3 to 5, sometimes more layers between the person that receives the care and the party that pays the bill. Mm-hmm. And I think that never occurs to people. And why would it, right? How do you combat I have great insurance, it just pays everything conversation, and I have a doctor? How do you combat that? I have many things to say about that, most of which should remain in my head. But personally,
I guess I'm being a clinician. If somebody's happy, I'm not here to combat somebody's happy situation. I'm here like, well, if you're happy and you feel that you're getting value, great. We're not here to disrupt that. We're here to help people who aren't happy with their health system and are paying too much.
The first question I would ask that person is, how much are you paying in premiums each month? And 8 times out of 10, they have no clue. They have no clue. It comes out of their check before taxes. It's just a deduction. They don't even look at that.
And not only that, their employer is paying a hefty part of that.
Exactly.
You know, I don't think you've ever had a conversation with somebody who gets their COBRA notice and they call you and they say, this cannot possibly be right.
So many times. I have teachers that are retiring. They're like, this is ridiculous. We can't afford that. I hear that all the time. Or people that do know how much they're paying in their premiums. But then, so we have plenty of people that have traditional insurance and come to us and they just want the level of service that we can provide. So many times we hear people say, I have great insurance. Let's run my labs through my insurance. Let's get this MRI through my insurance. We know where the best cash prices are for these services and how to get them. We advise our patients in that, but they think, oh, I have great insurance. I pay all this money every month. Well, unfortunately, we had a patient want to use our insurance. She had great insurance for an MRI. We could have gotten the same MRI for $450. This was in November of the calendar year. She had paid $0 towards her deductible. She had a $3,000 deductible, and the MRI ended up costing her $3,000, the entire deductible. If she would have went through us, it would have been a fraction, $450 of the cost. So you can have great insurance, but still pay more for services. Wes likes to say, it's a good quote, insurance a lot of times can be an exclusive club where you pay more for things.
This is very good.
Yeah.
A lot of the times that's the case. I see it honestly almost every day.
Oh, we see it all the time.
Yeah. When patients telling me, well, my Viagra costs like $100 to fill. And I'm like, well, did you know you can get it cash for like $10 a month? Or these are ones I just see a lot. I think young male doctor, or my testosterone costs so much money. Well, do you know you can get that for $10 a month? Or I have a patient who has really good and has 2 insurances. They have, I think, United or Blue Cross Blue Shield, one of the big insurance companies, and they have Medicare. And they got an annual panel of labs. And I don't know if you noticed, but a lot of insurance companies are now denying annual as a code. And so they're getting a bill for just cholesterol, sugar, kidneys, basic annual labs for $450. And they have 2 insurances, and those cost cash $25 worth of labs that we got. It's just.
I have a big headache with the lab people. And I think one of the things that I hear a lot is, well, we get the best discounts. You know, I think most often those discounts are a made up number from a made up number that has no relation to reality. I know you and I have had some conversations about drugs like Ozempic and who needs to be on what and how you get it and where you source it. I think that prescriptions are incredibly overprescribed. And that when you have a relationship with a physician, that your approach tends to be less is more because you have more conversation. Mm-hmm. How does that impact somebody's health over the long term?
I think the most probably costly example of the opposite of that, where we see in this model, is going back to the referral kind of trigger happiness of the traditional model and the medication trigger happiness. We can extend it to that. When you have time to get to the root of a problem, you can adjust the lifestyle stuff we talked about. Or I totally encourage, I love referring to physical therapy. We have great insurance and cash-based physical therapists throughout San Antonio. But actually, there's a lot of information online, and I don't want to undermine my physical therapist people, but I usually recommend my patients do a week or 2 of home-directed therapy, and I actually get out from my desk and I do it with them. So we'll do like a squatting pattern or a glute exercise of some kind for hip problems or something for different musculoskeletal issues. We'll do that in person. I'll sit right next to them and do the exercise with them because we have time. So now they don't need necessarily a orthopedic surgeon referral or an x-ray yet, because they have easy to access therapy, whether that's a cash pay therapist or those online resources.
Or those medications they were taking every day, like the NSAIDs or the muscle relaxers or pain medication.
There are long-term consequences to that.
Exactly.
There are. I think probably we don't need to prescribe pain medicine as much, although I prescribe anti-inflammatories like it's candy, to be honest. I think they're great short term, but they're very cheap too. So that's kind of irrelevant to the cost conversation. On the other hand, I would like to point out, since we're mentioning pain medications, like opioid pain medicines, which have gotten a bad press in the last decade, that bad press has led people to have unable to access clinicians that can prescribe those things. I get some patients, and we're not a pain clinic, so we don't usually start pain management or increase opioid pain management long-term in our patients, but we will continue it. And that's because we have time to do all the necessary safety protocols and discussions with the patient to safely prescribe opioid pain management long-term. And I get so many patients who have a severe unoperable condition that causes severe pain, and they can't find anybody who will prescribe pain management for them, especially if somebody is not insurance-based, doesn't have insurance.
I have a client who was having an MSK surgery, a necessary MSK surgery, because that's its own discussion. But and her surgeon would not give her pain medication prior to her surgery. I was a little surprised by that.
Yeah. I know that there are some studies that show like anti-inflammatories have a similar effect in certain cases, but yeah, surgery often should require at least the option, right? So if pain is at maybe it doesn't need to be automatically scheduled, but it can be an option if somebody has a pain level over 8 or whatever number they decide on or agree on. And in those cases, it's extra important for the clinician to be accessible to the patient for those kinds of situations, because let's say a patient does have severe pain. Well, one of the scares of just treating it with pain medicines, you could be covering up a post-op infection or something. And maybe some of the fear is that if they just have pain medicines, they'll just take it when they shouldn't have that degree of pain. But in direct primary care, our patients can call us or text us anytime. Well, we don't do text after hours, but they can call us anytime, and they can text us during the day with any questions, and we get back to them within 2 hours.
Let's talk about after hours care, because I think that's a very strong value proposition. And I think most people are quite respectful of everybody's time and every clinician's time. But if it's 9 o'clock at night and I'm not quite sure if I need to go to the emergency room, it is much more beneficial for the patient to have access to somebody to say, "You're okay, do this," or maybe you should go to the emergency room. So it's better for the human, right? But it's better for the plan.
Definitely. DPC is known to reduce urgent care and emergency room admissions. There's been many case studies that shows decrease in claims with direct primary care as part of the healthcare solution.
And I would assume that I have this theory that urgent cares are everywhere because people can't get to the doctor.
You're exactly right.
Exactly. So, I think urgent cares have a place, but honestly, I think the rapid growth of urgent cares in the United States is basically a symptom of poor primary care. If primary care doctors had adequate, reasonable access, the need would drop significantly. It's all about access. And actually, what's funny is a lot of those after hours needs could have been taken care of during the day, but it's not even that there's not access in the evening. There's not even access during the day for patients. Mm-hmm. So things get pushed until the evening, and now the doctor's not available. So access day and night is what's needed and been the problem, and what's led to the overutilization of ERs and urgent cares, and also the underappreciation. And I think patients have kind of lost interest in primary care because they don't see the value in it anymore. Right. If they can't access it.
We get calls every day with simple health issues, urinary tract infection. They are concerned they may have COVID, and they call their doctor's office. They're already established at that clinic. They don't have availability for 3 months to see them.
By then you're either better or you're dead.
So they're forced to go to urgent care. They have probably a $200-$300 bill, which would buy them 3 months of care at our clinic.
I had that experience. I had a traditional fee-for-service primary care doctor who, when I thought I had COVID, wouldn't even get on the phone with me, told the woman that answered the phone, because hospital-owned practice, that if I was concerned, I should go to the emergency room. Now, given what I do you think I'm going to the emergency room?
No.
So, I mean, I was just like, personally, if I were a regular person, I didn't know better. I would just be like, oh, I should go to the emergency room, where I would have been admitted to the hospital and spent 3 weeks. Instead, I just called a doctor friend of mine and said, walk me through this. But if you don't know, you don't know. I had another client who had elevated high blood pressure, and she went to the emergency room and her blood pressure was coming down, and they insisted on doing a head CT. I believe that there's 1,000 times the radiation in a CT than there is in an X-ray. Do you want that in your head? How do you talk to people about that?
Yeah, let me say this. Do not go to the ER for high blood pressure. You got to get a hold of your primary care, because and an ER clinician will say the exact same thing. Don't come to us for just high blood pressure. Your blood pressure, if you don't have symptoms, but your blood pressure is like 160, 170, that seems like an emergency, but you need to get a hold of your primary care first, because ER is going to get it down with medicines that only last for 12, 24 hours. They're going to get it down on paper so they can safely discharge you, but the next day it's going to be high. And most likely, if you're at a traditional practice, you can't get in next day. Right. And so really blood pressure has to be managed by a primary care. Yeah. So got to say that for sure about blood pressure.
And these doctors that work in the traditional setting, they're not bad doctors. And
no, not at all.
They do care. They're working in a broken system in which they're incentivized to see as many patients in a day as they can.
They have to. Rather
than keeping their patients healthy. So in direct primary care, instead of focusing on quantity, we focus on quality of patients. And that's, I think, the main difference in how we're able to do that.
One of the ways that you do that is by controlling your panel size. And for people who are listening, a panel is how many patients a doctor has charts for, basically. So your panel size is considerably smaller than the panel size of a traditional fee-for-service doctor.
Correct. Yeah, the average direct primary care panel size is 300 to 600 patients. 300 is on the low side. Many are over 400, so around there. I don't know the numbers exactly, but I think there's been ranges in a traditional clinician to see 2,000 to 5,000 panel size. So
it's about 10%.
Yeah, we're 10 to 20% of a regular panel size. And so that alone is a statistic people really need to take away from the comparison between direct primary care and a traditional primary care is panel size. That's really the only thing you need to know in terms of service. If I can provide literally 4 to 5 times the medical service per patient.
Correct.
And many people are concerned with this fact. Well, we already don't have enough primary care doctors. How is this going to help our system? It's going to cause access to be even lower. Well,
I have a lot of thoughts about that.
By changing the way primary care works, it's going to make it so much more attractive to people to actually go into primary care instead of going into specialties. So that is a fundamental way that direct primary care can flourish. And
a lot of primary care residencies, despite the fact that many residents didn't match. I don't know if our audience has heard of the match process, meaning medical students go into residencies for a specialty or for primary care. Well, primary care, because of what it's become, is a less desirable field. I'll admit it. I mean, there's actually, despite the fact that some residents didn't match at all into residency and they have to just wait another year to start practicing medicine, some of the other end of the match, some of the residency positions in primary care didn't fill immediately. And that tells you people would rather just wait a year to become a specialist rather than primary care, even with all that debt and the fact that they wouldn't be a doctor. So it's not a desirable field right now in terms of in the traditional model. I think that's going to change as DPC grows, which it is growing rapidly, and the awareness is getting higher in the medical community. But let's look at where people train in giant healthcare systems, where the incentive is to keep people in that system in that less desirable position. But they won't be able to hide DPC for much longer from our residents in training. So like Jen said, make primary care and direct primary care more desirable, and you'll have more clinicians. That's a slow process, and it's going to slow kind of the access to DPC. The other thing I would point out about the fact that there may be not enough docs for our clinicians in general to just have 400 or 500 patients is I've thought about this a lot. And the truth is, I think having 400 or 500 patients where you're providing great medical care for and saving them money is better than having 2,000 to 5,000 patients that I'm bankrupting every single day.
Or that have lower life expectancies.
Yes. Let's talk. We have somebody who's listening in whose specialty is kidney disease. Talk about how you can help somebody navigate through kidney disease, keeping them out of a dialysis chair for quite some time, maybe forever, because that is a tremendous burden. It is a horrible way to live, and it is a tremendous financial burden for everybody involved.
Yeah, so kidney, I will say there's different stages of kidney disease, all the way to what you described as the end-stage kidney disease, where kidneys are no longer functioning and you need dialysis to live. The truth is, well, the number one cause of kidney disease, the top causes of kidney disease in the U.S. is high blood pressure and diabetes. Those are what cause the majority of kidney failure and kidney disease. So the goal is obviously not to just, again, like diabetes, we don't want to just treat the kidney disease. We want to treat the causes. And so having adequate primary care to control diabetes or reverse diabetes, I want to make that the buzzword of today's management of diabetes, is reverse diabetes. To be able to do that and control blood pressure adequately by having the access. So my patient's like, hey, my blood pressure, they can just call me if their blood pressure is high, and we can make an adjustment and monitor and have them check at home and communicate about readings. So controlling those conditions is really the most important part. That's really what directs how somebody's kidney disease evolves. The other thing is, a good primary care clinician can manage early stage kidney disease. Now, depending on their comfort, there's different levels of comfort, and maybe a nephrologist is needed to rule out some other possible causes of kidney disease, especially if trajectory is looking bad. But if they take a little bump and they had clear cause, clear uncontrolled hypertension for a while, high blood pressure, and that's controlled now and it's stable, primary care can manage that as long as they're continuing to manage those conditions, and as long as they understand the great tools to optimize the kidney condition. So there's some blood pressure medicines that are preferred in those cases, and now there's some diabetes medicines that are actually helpful in preventing the progression of kidney disease. And that to do that, you have to be up to date with the knowledge. You have to have time to spend with the patient and time to study and time to read the articles on how to manage these things. And that's what DPC clinicians have is time.
Yep. Do you ever get pushback about, well, now my employer is going to know what's going on with my medical history or with me right now?
Jen, I'll let you talk about this a little bit.
I don't think I've ever had that concern. We have about 25 businesses we work with. And, we have a privacy policy that each person signs in the beginning that there's no reason why the employer should know anything about their employees' healthcare information.
Yeah. And what about everybody I have to go to this one place? Do you ever get any pushback about that?
So that was a big reason why we decided to create San Antonio Direct Primary Care, where this year we'll have 3 clinics and 4 clinicians to choose from. We don't want that to be an issue. And if there is an employee that has a primary care doctor that they love and they have a great relationship with, they can absolutely continue with them. And we'll be here for any urgent needs that come up when they can't get in to see their primary care that they love.
I think that's a very important thing. That somebody has a relationship with you doesn't preclude them from keeping something that they already have.
Absolutely. If someone loves going to their endocrinologist and it's absolutely something that Dr. Wes can manage, we do not want to get in the way of that relationship. And we'll definitely support the patient in whatever they decide with their healthcare.
Before we wrap up, what would be your best advice for employers considering DPC for as either for everybody or as an option for their employees?
Say reach out to a local DPC and see what they have to offer. See if they have discounted rates for employer groups. See what all entails. I think really more employers would be willing to make this change if the awareness was out there. So that's what you're helping with, Allison. So thank you for that. But yeah, I think just reach out to your local DPC. Most DPCs in San Antonio are more than willing to accommodate employer groups and would be willing to take them on.
And I think we're very fortunate in San Antonio in that we have a robust cash pay medical community. It is not difficult to find cash pay pricing for imaging. Labs have cash pay pricing. It's probably not as good for me, the person, as it is for you, the clinician. But it's much better than insurance pricing. What do you see in your future? Will you continue to expand in San Antonio? Will you grow a little bit outside of San Antonio? Where do you see this going? And what do you see happening with the insurance? I know you talked a little bit about insurance alternatives. And for those of you that are listening, that typically means a health sharing arrangement. And we're not going to talk about that today. If you have any questions, let me know. But talk about sort of where you see smaller employers going. If you have more than 50 employees, you can't do a health sharing arrangement. But if you have under 50, you have quite a number of those clients.
We do. Yeah. So in the short future, we're talking about plans, we are opening up another clinic. Currently we have one in Medical Center. We have one downtown King William, and we're opening up a 3rd clinic in Alamo Heights this fall. I see us growing to more clinics in San Antonio to span the entire city. A great solution for those smaller employer groups is a combination of direct primary care and health sharing, as you mentioned. It saves on premiums each month. It saves about 50%. And like we mentioned earlier, better access to care. So
and significantly cuts down on the out-of-pocket cost for the employee. Let me just throw that in there. Not for everybody, but it can be incredibly effective.
Exactly. And the main way that we're getting more employer groups is word of mouth. And that's how we get more patients too. So just getting the word out there, our best advocates are our current patients and our current employer groups. And I think the more awareness there is out there about us and how we can save people money and get them better healthcare, the further along DPC will be.
So I think we'll wrap it up there. I would leave people with, think about how you purchase everything else, and healthcare is not everything else, but some of those fundamentals can apply. And as an employer, I hope you apply them to how you measure your plan performance. And as an employee, I hope you measure them in terms of what you pay out of your pocket, and ask a couple of questions and see what remarkable things can happen.
We hope you've enjoyed this episode. Raising the Bar is powered by LT Consulting, the country's leading independent expert in healthcare cost containment. Astute employers know there's a better way to offer health insurance, and we help them achieve it.